how we can optimize antimicrobial stewardship and instigate appropriate use in various different healthcare settings. What we've got to do now then is put that into practice, and we've got to think about how we are going to optimize antimicrobial use, first of all empirically, and then I'm going to build upon that initial empiric management strategy to then focus on ESBLs. From the conference program, my colleagues who are in the room are going to speak about MDR SUD, CREs, and Acinetobacter baumannii later. So let's start then by thinking about the patient journey. So patient presents to ED, and then patient ends up in a bed. But that is a gross oversimplification of what you and I know to be an incredibly complex first few hours. So the patient will arrive in the emergency department, be seen by a variety of healthcare professionals there, nurses, phlebotomists, radiographers, and then finally, eventually, the ED doctor, and then be passed on to the appropriate specialty. And that appropriate specialty will either be an acute medic or an acute surgeon, or if they are really unwell, then an intensivist. And that, of course, is a cyclical process whereby patients may be moved from medicine to surgery or up to intensive care, depending upon how their progress goes. Now, I'm not sure about your practice, but certainly in my practice, I don't have the time or the person power to be getting involved as an ID specialist at this point as much as I would want to. The patient has a variety of tests, and these come back from the laboratory, and then we often, as micro and ID people, get involved at that point. So what we need to do then is work on a way to optimize therapy in these first two stages, and particularly here in the emergency department. So how do doctors in the emergency department make their decision? How do they make their antimicrobial prescribing decisions? Because if we can understand that, then we can influence it. And as Alison said, Tim Rawson is a legend in his own time and is particularly good at asking difficult questions of all of our colleagues. And in this piece of work, he did a nice qualitative approach which looked at ED doctors and acute medics and asked them how they arrived at their decision. So if you think about how you arrive at your decision to prescribe an empiric antibiotic, it probably looks something like this. Well, certainly mine does. You look for, first of all, have they got an infection with their physiological changes? You think about where the infection is, you ask for some investigations, you how bad it is, and you start therapy. But look at just in that determining severity section, ED doctors, at least when Tim Rawson went and asked them, do take into account the likelihood of that patient having a resistant organism. I remain to be convinced that what these ED doctors said to Tim, they actually do in real life. If you push emergency room doctors as to how they operationalize that, how they determine the likelihood of the patient in front of them having a resistant organism, many of them say aspects of what Mario Bassetti has put down here. So they suspect that if patients are immunocompromised, or if they're elderly, or if they've had a recent hospitalization, or if they've come from another healthcare organization, they are more likely to have resistant organisms. And that is probably correct, certainly in my experience. And Prof. Johnson and Prof. Tomborello have enumerated these using two different and come up with reasonably good, if you look at the positive and negative predictive value, scoring systems to determine whether somebody is likely to have a moderately resistant organism, in this case an ESBL, at time 0. Now, what does that mean? That means that you can then derive a two-tiered empiric prescribing policy for your organization. And indeed, that's what we've done. So we have integrated these scoring systems, or specifically Tomborello's, into our ED scoring system. And if you do not meet the required score greater than 8, you get standard antibacterials empirically. So our setting is different to your setting, but for urinary tract infection, for example, you get comoxiclam. And for community-acquired pneumonia, you get amoxicillin and doxycycline. Yet if you meet Tomborello's criteria of greater than 8, then you don't just get co-amoxiclav for a urinary tract infection, you get a stat dose of amikacin, irrespective of whether you have hemodynamic instability or not. And that harks back to the positive predictive value of these scoring systems for influencing empiric antimicrobial prescribing. Now, what I would, again, forgive my ignorance, you may have geo-specific scoring systems relevant to Jordan, MENA region at large. And if you do, I would have a strong level of advocacy for you including those in your empiric prescribing policies as a decision tree for your ED doctors. If you don't have region-specific ones, well, there's a research opportunity, right, to take Johnson's score or Tomborello's score or any other scores you can find, verify and validate them for your patient cohorts, adjust them if you need to, and then integrate those decision trees into your empiric prescribing policy so that you can give the narrow spectrum where you can and then give the broader spectrum where you must. You then move the patients up into the ward. So the ED doctors have done their empiric prescribing. They've done it. Then you move them up to the acute ward. And then depending upon how much in your organization you have had an impact as a stewardship team, you will get a variety of feedback from your acute medics and acute surgeons. And this builds upon what Alison was saying earlier, in that if you want to enact antimicrobial stewardship, you must start at the top and diffuse down. And certainly Pravneeta Tama, who is a pediatrician in the US, but is very active in the world of antimicrobial stewardship, has been propagating these 4 moments of antimicrobial stewardship across the US. So we have the 5 moments of hand hygiene. Moment is a real resonating thing that WHO have pushed, and she's leveraged that to have now the 4 moments of stewardship. So do they really need antibiotics? Have I tested for the right things before I've started the antibiotics? We've given them some antibiotics, and we're now at day +1. Do we still need them? Can we tone it down, i.e. a daily review of whether they're needed, and then a real clear focus on duration? And that's really taking off across, and as I said, because it builds upon the WHO 5 moments of hand hygiene, that wording is still resonating amongst our clinical colleagues. So it's a really powerful thing to build on. Separate to the acute, the antimicrobial stewardship endeavours done on acute wards after the emergency doctors have just gone in there with their powerful empiric prescribing, you may, depending upon how good your acute receiving wards are, have then some further risk assessment for resistant organisms. And several risk scoring systems exist. So there is the ECDC scoring system for the likelihood of having a carbapenem resistant. There's the Public Health England, just recently updated in January this year, just before COVID, scoring system for determining whether you have a CRE or not. But then there's one further system, because both of these two, both the ECDC and the PHE scoring system, are tools for acute medics and acute surgeons and intensivists to predict whether the patient in front of them has carbapenem resistant organisms colonizing them. But what we're talking about here is empiric prescribing decisions. And whilst ED can usually decide ESBL, not ESBL, based upon Tomborello's scoring system, what we need to do is decide not just are they carbapenem resistant colonized, but are they infected? Is there gram-negative infection that you're trying to manage a carbapenem resistance? And Paul Tambaya's group from Singapore developed the GSDCS, which doesn't trip off the tongue, but it is a good scoring system. And it's a good scoring because it's got a really good area under the curve for distinguishing gram-negative sepsis patients from being those with susceptible gram-negative sepsis from those with likely carbapenem-resistant gram-negative sepsis in a Singaporean setting. Now, much as I was saying earlier, for ESBL scoring systems to insert into your prescribing policies, you need to validate these locally to Jordan or MENA region. We felt the need to validate Paul Tambaya's Singaporean scoring system, our UK setting. So as you can see, area under the curve in Singapore, very good, with a ROC of 0.77, really good. And when we transpose the Singaporean scoring system, which is a different setting to the UK, to our London setting, we find almost exactly the same data. So this is a translational scoring system that will predict not just is the patient in front of you with gram-negative sepsis got got a susceptible organism, but then has it got a carbapenem resistant organism? So your empiric prescribing before you get any lab results back can therefore take note of that, and you can build upon those earlier pipeline drugs I was talking about earlier, based upon what you know about the patient and whether they're likely to have a carbapenem resistant enterobacteriales or Pseudomonas or whatever. So that happens. So that happens in the acute wards. But as we said, the patients move around the acute wards. And they move around the acute wards, acute medicine, acute surgery, ICU. And in doing so, they don't just have their admission risk of having a resistant organism. They then accrue additional risk from being within a healthcare environment. And with as much infection prevention and control input as we would ever wish, we still do have an unfortunate degree of healthcare associated infections in many UK organisations. So receiving intensive care units have to go one step further to adjust and just titrate their scoring systems to see what is the likelihood of patients coming now from an acute medical ward into an intensive care ward to have a resistant organism, because that's going to further feed into their empiric prescribing. Because whilst their, Tom Borello's initial ESBL score might have been very low in ED, and they may have just given Comox-Clav or amoxicillin or something simple, and then the medics redid their CRE scoring system and found it to be very low, and then the medic hung around on the acute medical wards for a week or two and then deteriorated with a nosocomial infection. At that point, you need to redo your scoring system and redose your empiric prescribing with an appropriately spectrumed antibiotic. Integrated TIMSET's scoring system into our ICU admission pack so that the empiric prescription, if you want to call it an upgrade, whatever you want to call it, but the admission antimicrobials given to intensive care patients when they're admitted is optimized. And of course, as Alison said, surgeons are a vital component of the team, but are a reasonable law unto themselves. And as Alison commented on, they have their own hierarchy. In that, surgeons often make a decision to prescribe antimicrobials, but are not so concerned with which antimicrobial. And so managing to do, as Alison said, and ingratiate yourself with the senior surgeons and really instill your empiric prescribing policies with them just facilitates that whole conversation, because some of my best friends are surgeons, but they see one antibiotic as being the same as another. So if you can tell them your opinion, then they often do this. And then, of course, after the patient has come in and had some empiric antimicrobials, you start then to get some lab results back, whether you're doing 24, 48, 72-hour turnaround disk susceptibility testing, or whether you're doing 14 to 24-hour liquid media susceptibility testing. Finally, hopefully, you start to get some results back, and then you can switch from making empiric prescriptions to targeted prescriptions. We're going to come onto that in 1 second. But the joining factor there, the joining factor that often brings those lab results back to influence the empiric prescribing is us. Using us in its widest sense of doctors, ID doctors, microbiologists, ID pharmacists, ID nurses. I almost don't mind what your base degree is, as long as you have a good knowledge and a good understanding of antimicrobials and organisms. So when we're then feeding back these decisions, we're doing it into the culture of that team. And certainly I am aware that myself, when I'm switching from empiric to targeted antimicrobials, I adopt different mannerisms depending on whether I'm talking to surgeons, medics, intensivists. I adjust my approach.